Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. And today we're going to be talking all about birth control with Dr. Shieva Ghofrany. Dr. Ghofrany has been an OBGYN since 1999 and is co-creator of Tribe Called V, a virtual platform whose mission it is to increase knowledge to decrease anxiety for all things women's health. She is active on social media, has experience consulting, takes speaking engagements, and is frequently quoted in online publications such as Self, Huffington Post, and Parents. She has been listed on Top Doctors with Castle Connolly many years and has been featured on verywell.com, WebMD, and in the PBS series, Human, The World Within, now on Netflix. So welcome, Shieva. How are you?
I'm good. How are you?
Great. I really appreciate you joining me today to talk about something like so simple and basic, because I know you have a vast experience talking about a lot of different topics, but I kind of felt like it was important to talk about birth control because there is so much misinformation out there and, a lot of fear mongering about it.
Yeah.
But so I wanted to start I always start by asking guests to just, tell me how they came to be doing what they're doing. You have such an interesting background. So
I know. Well, I know. And offline, we were chatting quickly about, first of all, I did not get to tell you that you have the best named podcast ever. I mean, when my business partner and I were trying to come up with names, we tried to think of any interesting, fun name, and so many of them were taken, and I love yours. I always try to shorten what I say about how I got to this, and it's hard to nugget it, but I became a physician because my parents were doctors, and they very clearly told my sister and I not to become doctors unless we loved it, because they recognized how wonderful, but how grueling it is. And so I really took a long path. I switched majors many times in college and then took pre-meds after I graduated from college. And the good news was that really helped me clarify that I love this, not because I love actually being a doctor per se, but I always say I love engaging with people, and medicine happens to be the medium with which I'm able to engage, because I didn't purposely intend to do this in the same way that many people do. And then I, like you, was a general OBGYN when I finished residency. So from 99 to 2003, I was a resident. And then I started a private practice. I joined the private practice that I'm still in right now, doing general obstetrics and gynecology, which for those of you out there, that means we deliver babies, we take care of, the annual exam, pap smears, all kinds of gynecological cancers, birth control, polycystic ovary syndrome, fibroids, the whole gamut. And then 3 years ago, I really, for many different reasons, decided that I needed to work less in the office so that I could do more consulting, more public speaking, and more educating. And most people, as you and I talked about, stop the obstetrics and continue the gynecology because it takes away from your call at night, because the call at night is grueling. And I recognized that if I did that, even though I love gynecology, I wouldn't have time during the day to actually do the work I wanted to be doing outside, because I'd have to see gynecology patients all day. So I actually deliver babies with my private practice, and then separately have a telehealth practice in Connecticut and Florida for midlife. So basically for perimenopause and menopause. So, it's wonderful because I get to see all the patients that we deliver babies with insurance, with Medicaid, and really know that I'm honoring them and taking care of the people who don't necessarily, some do, some don't have resources. And then in the menopause space, the good news is I get to spend even more time, but because of the trade-off, which is that it is for more resourced patients who are not using insurance. So I kind of feel like I'm getting to kind of level out in all the different ways. And then the kind of added benefit is that I joke I have like the what's what of gynecological health, because I've had from HPV, endometriosis myself, to 6 miscarriages and 3 babies and a vaginal birth and C-sections. And then I had ovarian cancer 9 years ago now. And so because of all that, it's kind of helped me really hone understanding why women are so anxious about so many things. And it's because of lack of information, and then misinformation and disinformation. And so I really want to try to help with preemptive knowledge. And birth control is such a relatively simple and yet completely complicated, as you and I know, right?
Yes, I think
That
there's
leads to
so
health.
many different options and it's overwhelming and it's hard to cover all of them in the
Yes.
office.
Yes.
So before we move to that, though, I do want to comment about how amazingly candid you are on your social media about your health journey and I mean, you are a rare person that has experienced so many women's health issues personally. And I'm really just impressed with how much you share because I think, and it probably does make you, a rare person also because you can relate so much to patients on their level and the fear they may have about a new diagnosis.
Yeah.
And my God, being an ovarian cancer survivor is rare too. So many ovarian cancers are diagnosed late, right?
Right. You and I know they're diagnosed typically stage 3 and 4 because of, again, lack of information or mis and disinformation. And I know we're going to talk about birth control, but one little nugget I would love to just continue to sprinkle out there for, I would say men and women, but because I primarily take care of women, I wish more people were honest about and transparent about themselves and their health journey, or even to their families, their marriages, anything. Because as I always say, when we all talk about what we're each going through, inevitably everyone around us has, I always joke, it's varying levels of Venn diagrams, right? Like you and I might not have experienced all the same things, but we've overlapped with a couple of them. And you overlap with some of your other friends, and I overlap with some of my other friends. So we're all overlapping. And once we transparently talk about it, then there's really nothing to be embarrassed or worried about. And then the preemptive knowledge could be so much better because we could each teach each other, even those people who don't have access to a gynecologist who talks a lot and talks fast, like you and I might. They could teach each other things in a more accurate way, or they could align and bond over their shared, whatever it is. And because I think we know this, no one is getting through life unscathed, right?
Right. Exactly. It's just a human condition, all these things we go through. And I have thought about this recently, like how interesting it is, like, social media and these online platforms, and you have an online platform as well. Like, I just love how it's brought women together we no longer have those ancient communities or tribes, but now we have these online, and what a perfect name for your online platform as well, tribe called V, because we're developing these online communities where we can share about our personal experiences and not feel alone when you're going through something rare, right?
Right. Well, and the truth is, it's almost never rare, right? I mean, I always joke with my patients that when patients say, like, I have something embarrassing to ask, you and I both know that 99.9% of the time, it's not that embarrassing because it's actually not unique. And I always joke, like, you don't want to be unique when it comes to your medical care. You want to be unique as a human, maybe. But the good news is the majority of what people tell us isn't actually unique. And I think if women recognize that, they would be so much less anxious. They'd be less embarrassed because they'd recognize that, oh, wait a minute, so many other women have had miscarriages. It's so sad. It's so devastating. But if they knew ahead of time that it was common, they could look at all these examples of women who already have become mothers, for example, right? Without having to think that it means that they'll never parent. So there's so many examples of that. So I'm glad we're going to use birth control as a way to kind of.
Yes. Thank you so much. So, okay. So, I started by telling you that I just see a lot of, misinformation online about birth control and fear mongering. And I see it in the office too. So I thought it would be good to just start with the basics, like what are all the options out there? Maybe I know it's only an hour recording, so we can just talk about what it is, maybe how it works, how effective these methods are, and common side effects, and also like maybe dispel some myths that you've heard. Okay, I guess we should start with the non-hormonal options, right? So let's see. I have something very popular now are these fertility apps, right?
Yes.
People using fertility tracking or cycle tracking rather to track their most fertile and least fertile times, right?
Yes.
Do you want to talk about how that works?
Yeah. Here's what I would say first too. When people say to me, I always ask in the office, as I'm sure you do, are you using, do you need, and are you using any kind of contraception or birth control? And often the answer is no, which you and I would kind of take literally to mean, oh, that means you're trying to get pregnant or you're not having sex with a male partner. But in reality, what patients often mean when they say, no, I'm not using birth control is I'm not using the pill, because many people still equate birth control with the birth control pill. So first, I would love for us to dispel that myth that to you and I, there are multiple forms of birth control, including, I mean, I joke with patients all the time. Do you mean that you're not using any formal form of birth control, but you're, for example, withdrawing or pulling out, which is not a very effective form of birth control, but it is still a form of birth control, right? So let's start with withdrawal, which is a non-hormonal form of birth control, which means the man pulls his penis out before he ejaculates. And it's not so effective, but it's not terrible. It's about anywhere from 80 something to 92%, they say, in the best case scenario. So I would never endorse or encourage it in any person, regardless of age, who would not want a pregnancy. In other words, if you are not okay with a failure rate of maybe 10 to 20%, we wouldn't do that. And then the fertility tracking apps, or like you said, the cycle tracking apps, because you and I know them initially as the ability to track when you're ovulating with the intent of getting pregnant, right? That was the initiation of what you and I saw a lot as residents and physicians. And then the side part was people who had done natural family planning, which is what it used to be called, in the more religious clinical circles, like Christian circles, because people weren't using birth control and they were trying to track their fertility. And the specific way that it used to be done is with their thermometer, right? We know that you had to check your basal body temperature and your cervical mucus, and you had to check how stretchy the mucus was. And it was very cumbersome and still not necessarily a tool that could be really successful. So the failure rate was still pretty high with what we used to call natural family planning. Now, because of these apps, people have choices of either just tracking the length of their cycle, where you would input the first day of your period, because that's the first day of a cycle is the first day of your period for everyone listening. People often think it's the last day of the period, but it's the very first day that you have real bleeding. It's the first day of your cycle. And these apps will then kind of calculate on average how long your cycle's been and give you a window during which you're more fertile. And if you choose not to get pregnant, that window would be when you avoid it. So one way is just literally measuring the amount of time between your cycles. Then the second and third ways now are either saliva testing or urine testing, where you either take pictures of the results or there's some fancier ways to do it, and then it will track through actual hormones what's going on. I think it's really intriguing. I don't think it's wrong to do it. I still think it's not, even though the published data would tell us that the efficacy can be as close as 99%, I think it requires a lot more work. And I think that many people, for example, if you take a busy physician who my sleep is very disordered, things like that, my ability to track would be more challenging. So I would hate to hear the information that it could be 99%, digest that, think it works that way for everyone, and then potentially get pregnant when it's unintentional, especially right now when we're worried about reproductive rights. So I don't think it's bad to do it, but I would say it falls into the category of, I personally wouldn't say it's as effective as I would like if I'm in a position where I would be devastated to be pregnant. That's one aspect. The other aspect, not to fearmonger, but I do worry a little bit about the ability of these external apps to track our data, track when we're having our period, track maybe when we've missed our period, be able to track if we're pregnant. Because unfortunately now with the conglomeration of data and the fact that some of these apps don't necessarily de-identify and they can sell off your data, does that pose a concern, especially in states where people don't necessarily have the same reproductive rights as other states? And I think that unfortunately that has to be pointed out, even though it sounds like we're fear-mongering, but we know that that can happen.
Absolutely. I mean, I think we see right now in this environment that, tech and the government are kind of intertwined. We do have to fear that. Another thing I want to mention about the fertility tracking apps is I think they were probably most effective for women with really predictable cycles. Because if you have longer or shorter cycles, those apps are not going to be accurate in being able to predict your most fertile times,
Right. Because you and I both know if someone has a very predictable cycle, then the irony is they don't really need the app. They could just calculate when they're supposed to get their period. Now, again, with the advent of these other aspects where they're checking saliva or urine testing, of course, it becomes more accurate because they're using other assays. But still, you have that aspect where they're capturing your data and they're either profiting from it because they're selling it as de-identified, but selling it, or they don't necessarily all need to. I mean, I think there's a lot of fine print that we don't always read. So I do think it's fascinating. I'm glad in a way it's going to lead to more innovation in women's health, hopefully, if we really understand the nuances of the cycle. But I'm worried about the negative aspects that can come from it before we actually reach a level of collecting data that's going to be helpful.
I don't know how common this is, but I do want to say that I saw some woman on social media say that she was using one of these apps and she got busy during one cycle and forgot to log in, her period date. And she mentioned that someone came to her door from a pregnancy crisis center, those centers that are kind of pro-life centers.
Yes.
And I was, obviously I did not check her background and see how.
Right. If she was telling the truth. But yeah, but it could happen.
Exactly. But I think that definitely struck me as something like, wow, we should be worried about that because you don't want everyone at this, who knows who's on the other end of this technology to know that you've missed your period, and you could be pregnant.
Yeah. I mean, and even outside of the law and safety, which is absolutely our biggest concern, but even just like, I don't want them to tell me that now I need my tampons. On one hand, it sounds like, oh, it's so convenient, but it's one more way these companies who are buying data have access to us, right? And that we know that can be used for ill. So I think we agree. So I don't think it's bad, but it's not what I would personally endorse for. I always say like my sister or my daughter or my niece, I would, unless they were trying to get pregnant intentionally, in which case,
it is pretty easy to track on pen and paper. And, and take your temperature because your temperature goes up after you ovulate and track your mucus. Your mucus is thinner when you're fertile. So, okay. So let's see. Yeah. And I say the same thing about these two methods, like the withdrawal pullout method and the tracking apps is, it's probably best for people who are okay.
Yeah.
It wouldn't be getting pregnant.
Right. Yeah. I would say if you wouldn't be devastated, great.
Right. Yeah. So, okay. Next up, condoms.
Condoms, yeah.
Pretty common.
Condoms, I mean, listen, and I say this anecdotally.
There's a male and female.
There's male and female condoms. So let's talk about the male condoms first because there's so many more, of course. But the male condom can be very effective. The published data would be in the 80s% wise, because for perfect use, you have to really use it correctly, meaning it has to be put on the right way. I always say to my patients, it has to be used every time and the entire time, meaning he can't put his penis in, think he's going to start without it, pull out, and then put the condom on because we know that there might be a little bit of semen that leaks out ahead of time, or he just doesn't recognize that it's too late and he doesn't pull out on time. And you need to make sure it hasn't broken, and you need to make sure you're using lubricant that is not going to harm the condom. So for example, if you're using any kind of oil lubricant, which you might need, that can actually break the condoms. So you have to be more cautious with that. All that said, I think condoms can be incredibly effective. I would say in my 26 years of doing this, that I know, and I'm sure there are times I don't know, but of all of my patients who have gotten pregnant, when they say, I'm shocked I got pregnant because I've been using condoms, and I talk a lot to them, when I probe, all but one patient has said, well, I mean, but there was that one time I just didn't think it would happen, right? In other words, one patient in my 26 years absolutely used it every single time with her husband, even went so far as to check the condoms to make sure they weren't broken afterwards, and still got pregnant, which was surprising. Every patient otherwise, when we really, really talk about it, their response is, well, there was that one time. I just didn't think it would happen. Now, that's not to say that's always true. So again, if pregnancy would be devastating, I wouldn't rely only on condoms. But a nice thing to do with condoms that I encourage any patient to pursue right now is, if you're relying on condoms, preemptively purchase emergency contraception, because then the minute a condom breaks, you don't have to freak out and try to figure out what to do, or scramble and go look it up online, or like run to the pharmacy that's closed, or even worse, go to the emergency room, which is what a lot of patients do to get emergency contraception. You can have it calmly at home. And then if a condom breaks, you take it immediately. And as you and I know, emergency contraception is not an abortion pill. It is exactly what we called it, emergency contraception. So it's meant to be taken as close to the event as you can, as either a broken condom or unprotected intercourse. And it changes the environment so that you delay ovulation and are less likely to get pregnant. So I think it's really valuable for people to get that. And that's over the counter, as long as you're above 17. And if you're 17 or under, you can get it with a prescription and still have it with you. So I really think that's a valuable tool. Yeah.
Yeah, great points. And yeah, another thing you can add is spermicide, right? With condom use, because that's some people, which actually we can talk about spermicide next. But I think best to combine methods for even more assurance that you won't, get pregnant, have an unintended pregnancy. But yeah, and I've had some patients tell me they use spermicide alone, which I think is a gamble,
yeah,
but
a gamble,
it is technically a birth control method.
Yep. Again, lower efficacy rate. Yeah. I don't feel, unless you feel differently, tell me, I'm so open to always learning and hearing that the spermicide, that the world of spermicides has really evolved very much. We know that there's that alternative medication, Phexxi, which is the funniest name, which is not considered a spermicide. I actually think Phexxi is wonderful because for anyone listening, it's just a gel. You buy it through a prescription, which is a little bit cumbersome because you can't necessarily just get it from the regular pharmacy, but it's just lactic acid and it alters essentially the pH and really can be, relatively speaking, very effective, but it's still, I believe, about 90 to 92%. I don't think it's higher than that. So it's great with a condom. What's really lovely is that if there is semen, it can seemingly almost neutralize. I don't think they're legally allowed to say it, but it seems like it can neutralize and decrease the chance of bacterial vaginosis or yeast infection. So it's not indicated for that yet, but that seems to be a nice side effect. But in the
bacterial vaginosis and yeast infections,
because it's altering the pH. I mean, it's decreasing,
lowering the pH.
Semen. Yeah, it's decreasing the chance that the presence of semen. Because we know that semen, right?
Got it. Yes.
Trigger BV, bacterial vaginosis or yeast infection. So Phexxi kind of has that nice side effect, and it's not really a chemical because it's lactic acid, as opposed to spermicides, which the downside to spermicides is something that's going to really kill all the sperm can also potentially throw off the microbiome of our vagina, leading to other downstream effects like maybe yeast infections and BV. So I think the spermicide market, to me, doesn't seem to have evolved very well, right?
I mean, yeah, I would agree. The only thing is that with Phexxi, I feel like I've read that, there's just a little more risk of vaginal infections, actually. So, but you're right, it is lowering the pH. But I guess independently, maybe not when you're factoring in the semen, right?
Well, and I think what we're talking about when they said it was increasing the risk, I think if I remember correctly when we read the data, it was one of those things they had to report, but it wasn't necessarily because Phexxi itself was increasing it. It was that maybe some people who were using Phexxi, again, weren't using it with condoms or had more exposure to semen. In general, you can get increased risk. So it's hard to say it was causation. Who knows, right? But I think it's an interesting form of birth control that is valuable, but not necessarily as effective. And then female condoms, and then female condoms that many people don't know about, right? So female condoms right now are not widely used because they're a little more cumbersome. You can't just buy them over the counter. You need a prescription for the single one that's available right now called FC2. I don't think they've come out with any new ones yet to market. There is another company called LUWI, and it stands for Let Us Wear It. Sorry. And that's kind of a nicer, more nimble female condom because the female condom is, have you seen them in real life? I don't know if your patients use them, but it's very it's
only once. And it's a production.
I mean, I think the upside, just so anyone listening can picture, it's almost like picture a male condom, but it's bigger and it's got a ring kind of on either side. The upside is the woman gets to be in control. She can put it in way prior to having intercourse. It can just sit in there as a sleeve, essentially. The man doesn't necessarily feel the restriction of the condom around him. The woman doesn't necessarily feel the discomfort of a male condom rubbing against her in the same way because it's a little bit looser. Some people also agree, and I've talked about this with Louis, the company, that maybe it will decrease the risk of herpes and HPV because part of the vulva is being protected.
It's covered. Right.
So we don't have data on that, but that would make sense. The other thing is that it can rub up against the clitoris, which we know all the nerve endings to the clitoris are on the vulva. So that actually might increase some level of sexual pleasure. So there could be some really good parts if we can. Louis is still working to get off the ground. So if they can, or if FC2 really gets off the ground, I think it really offers a great opportunity for women to take that kind of stuff into their own hands.
Those brands. Interesting.
Yeah. Those are the two brands. Yeah.
So, okay. And then another thing you can use with these, with spermicide or this, vaginal pH modulator gel, Phexxi, is diaphragms. How often
Yes.
are you using that? I feel
Oh
like
my
they're
gosh.
making like a resurgence.
Right. I feel like they should because listen, I would say in my 23 years while I was in the office full time, seeing all my gynecology patients, I probably prescribed maybe 15. So diaphragms on one hand can be excellent because for people who don't want any hormonal contraception, that can be really attractive, even though there are pros to hormonal contraception that we'll talk about after. The downside to the diaphragm, which is why I think I probably prescribed it maybe 15 times in the 23 years that I was in the office full time. It's cumbersome because you have to come in to get fitted, then your doctor has to call in a prescription to the pharmacy, you have to pick it up. Then every time you use it, you can put it in up to 3 hours ahead of time with spermicide, but you have to reapply the spermicide every 3 hours if you're going to be repeatedly having sex, or if you've put it in 3 hours before you have sex. Then you have to leave it in at least 6 hours afterwards before you remove it, because you have to make sure the spermicide has killed all of the sperm. And you could leave it in up to 24 hours, but again, you have to remember to reapply spermicide every 3 hours if you're going to have sex again. So on one hand, it's nice because, like we said, not hormonal. On the other hand, it's a lot of work. In addition, you have to make sure you get it refitted. If your weight changes, if you've birthed a baby, there are certain reasons why your vagina might change in shape. And so it really has to be sized correctly. So I think maybe there will be a resurgence just as women want more choices. And I think it's a great option to know about. But as you and I know, it's kind of a hard sell.
Right. It just requires a lot of maintenance.
Yes.
So, okay, another non-hormonal option, of course, is permanent sterilization. I've definitely seen requests for that going way up.
Yes. Yes. And I think that the controversy you and I know is that there are many physicians, partially because of the patriarchy and partially because I think they're well intended, will decline or really try to dissuade women who the clinician perceives is either too young, hasn't had children, or maybe is going to regret it. And I think part of it is because at least my generation, since I've been a doctor for 26 years, really learned in our residencies. We learned about the data that there was a high rate of regret in permanent tubal sterilization, meaning your tubes were at the time cut, now we remove. There was a high rate of regret depending on the age of the patient. Plus, that coupled with the fact that it's not even legal from a Medicaid perspective to take out someone's tubes if they're under age 21. So there was all of this messaging to us that, like, oh, it should really be for someone who's older, who's already finished her childbearing and is in a monogamous relationship where she's not going to change her mind. And while on one hand, I think it's something to consider, right? We're there to really help our patients make these decisions. We also need to honor our patients. Ideally, assuming we've gone through the pros and cons, they should be able to assert and make their choice if we really believe in bodily autonomy, which you and I obviously do. So what's good to know for patients is that nowadays when we do a tubal sterilization, I'm putting it in quotes because we used to just cut a small piece of the tube out, which is why people thought we were tying the tubes, because we would tie with sutures two ends of the middle part of the tube, cut that portion out, and send it to the lab to be examined. But it was never that the tube itself was tied in a knot, which is, I think, is the misconception, because patients have said to us through the years, can you tie my tubes? Because they think that you can untie them. Right. So first of all, even in the old way, you could not untie them because you were cutting a portion in the middle. Then all the data came out that removing the tube entirely was not only more effective, obviously, because you weren't leaving two parts of the tube that could reattach and cause a pregnancy, rarely, but possibly, but also that you can decrease the risk of ovarian cancer, because now we have the data that ovarian cancer largely comes from the fallopian tube. So I feel like that has really helped us counsel our patients well. Though I'd still say that there are many patients, for example, in my practice, since I still deliver babies, any patient who's going to have a scheduled C-section, I'll bring it up with them. But I am, even myself, as unbiased as I try to be, more apt to bring it up with the patients who have either had more than one child already, because then I think they're probably ready to do something permanent, or if they're older, having their first child. If it's a younger person who needs a C-section that is scheduled, I constantly try to stop my bias from not asking. But I also have to do it gently, because some patients get actually almost anxious and nervous when you talk about it to them, because they think, oh my God, I don't want to do anything permanent. And so we have to make it really clear. Don't worry, we would never do anything permanent unless we absolutely talk to you about it. But it can be a great form of contraception because it can really make women feel very free, whether or not they've chosen to ever have children. Either they're completely done having them or they choose to never have them. So I think
very
it's a
low
wonderful
failure rates.
Yeah.
Less than a fraction of a percent. So yes, it can make you feel confident that you're not going to get pregnant. To your point, actually, I was trained the same way as you. So I've evolved. I've been evolving, and I've evolved because I also used to dissuade patients because of that data that what I was taught, which is that the regret rate is high if you get tubal sterilization done too early.
Yeah.
And so, now I'm just frank about it with patients. I'm more open to tying, or not tying, sorry.
Cutting. I always say
cutting and removing fallopian tubes in younger women, even in their 20s, because bodily autonomy. And I do think that the young women these days are more informed about their bodies and the options than maybe older generations. And a lot are choosing not to have children at all,
Yeah, absolutely. And I hope we get to the point where we truly have evolved as a nation where we really, really behave as if it is absolutely equitable to choose to have children or choose not to have children. I don't think we're even close to there yet, but I think we should. And I think, when we were taught about the regret rate, I never felt like I would dissuade a patient, but I always felt I recognized as I aged in my practice that I still was less likely to offer it to my younger patients because of the regret rate. I wouldn't talk them out of it if they wanted it, but I wouldn't necessarily bring it up. And the truth is that even my most educated patients to this day, when I bring up tubal sterilization at the time of the C-section, they're surprised, like, oh, I never even knew that was an option. So I really think the burden has to be on us as gynecologists to let every woman know that they have that option, whether it's during a C-section or remote from a C-section. It changes how we do it technically a little bit, but they have that option because so many women, even at the time of a planned C-section, will say, well, I think I'm just going to have my husband do a vasectomy. And while I always joke, like, I'm all for making the male partner do something, right? Because the women have done
yes, they've done so much.
But as I always say, if we are in there looking at your tubes and it decreases the risk of ovarian cancer, then it behooves you at least to consider it if you're ready to make that permanent decision. Yeah.
Yeah. And when I said dissuade, I meant more that I tend to share what our thoughts are that, what if you regret? And, we have long-term options that are just as effective, like the IUD. So I just like to introduce that, but you're absolutely right. I think that is terrible to be paternalistic like that and act like we know better than our patient who lives in their own body and knows what's best for them.
I know, but it is hard, right? Because you and I were trained in a certain way, so it's so hard to release those messages that we were taught and lived through.
Yeah. And I have to observe that about myself too, what you were just mentioning, like, do I offer it less? Probably. To women who have
and the honest answer is I think there's also pragmatism involved, right? Like, the truth is that we do assume that the older you are or the more children, you are more likely to want something permanent. That makes sense. And we have a limited amount of time in our office to really be able. So to say that we're doing shared decision-making and offering every option is just untrue and unfair to doctors and patients, because there's no way in our 15 to 20-minute visits we could do it. So so to defend us, I don't think it's terrible that I wouldn't offer a 21-year-old a tubal sterilization, right off the bat. Right. But I think it's good for us to just remind ourselves. Yeah. Good.
So I'm glad you brought up vasectomy, because why are we only talking about birth control for women?
Yes, exactly.
And I like to joke, like, when patients tell me, that their partner has a vasectomy, I'm like, oh, you have a winner. That's how gynecologists judge men. The willingness to get a vasectomy.
Yes, it's true. I mean, you and I both know. I can't tell you. I mean, I can tell you because you've experienced it too. The number of men, again, educated, good, kind men, who still will say to me, Doc, I don't know. Like, I heard that I'm always joke that they're like, there's that one guy at a cocktail party who told me it hurt, or this one guy at a cocktail party told me that it changed how he felt about sex. And I'm always like, wait a minute. Imagine if we talked to one woman who told us that our vagina or our abdomen were going to be altered after we've given birth.
Right.
We would never do this, or our breasts were going to change. So I do think we need to do better at educating. I wish urologists and primary care would do better at educating men. And I wish, and I hope for the future that men, the younger generations, will be more responsible in recognizing. There's that wonderful book, and I cannot remember the author, but the title of her book is Ejaculating Responsibly. And it's about the fact that we know every pregnancy starts with a sperm, right? Especially every unplanned. The only planned pregnancies that start with sperm are ones where they're in an IVF clinic. And those are very planned, whether there's a man involved or not. Every other pregnancy starts with a sperm. So we really should put more of the onus on men. And just so everyone listening knows, for a man to have a vasectomy is either sometimes in an outpatient clinic or even in the doctor's office. often under local anesthesia. So I don't even say it's a surgery. I call it a procedure because I find that that's less onerous. Whereas for a woman, they can only have their tubes removed either under general anesthesia if they're not pregnant or during a C-section if they are pregnant. And so while they're both very safe, it's certainly even less surgical risk for the man to have a vasectomy.
Yes, absolutely. Tubal sterilization involves abdominal surgery for women and any, so the surgical risks that come with that, which is very different than an office vasectomy. Yes. So and I love when we're talking about permanent sterilization, I do like to give patients info about both, even if the partner isn't there, like handout about vasectomy. Yeah. So always bring it up, Yes. Yes. So, okay. So another non-hormonal option, of course, is the copper IUD.
Yes.
So tell us about that.
So let's first talk about IUDs in general. I don't know if we're going to be showing any of this, but I always have
IUDs.
I have my IUDs.
So, I love that.
Yeah. So the intrauterine device, and anyone watching, this is the vagina, this part that looks like what we call rugae, which are these little ridges in the vagina. That's the cervix. And then this is the inside of the uterus, or what we call the endometrium. And an IUD literally fits in there. And this is actually a pretty appropriately scaled model. So many women, as you and I know, think their uterus is like this big, when in reality, you and I know it's like I always call it a small upside down, like a very small pear. And so the intrauterine device can be copper or progesterone. We'll talk about the copper one, which is a little T-shaped piece of plastic in America. Other countries still have some varying shapes, but for the most part, it's a T-shaped piece of plastic that is wrapped with a copper coil, and it's inserted through the cervix into the uterus, and then it sits there and it creates a non-infectious, ideally, inflammation so that the cervical mucus changes and the inside lining of the uterus has a little bit of inflammation, so that first and foremost, the sperm ideally are not going to get up past the cervical mucus and the change in the reaction. But also if they do get inside, now the inside of the uterine lining has enough inflammation, again, not infection, but inflammation that if the sperm meet the egg, they won't implant into the uterine wall. So it can be an amazing form of birth control. It can last 10 years, which is wonderful, right? For anyone who has had it placed. The downsides, I would say, are that placing it, as you and I know, can be either very easy if someone has already birthed children vaginally, or their cervix just happens to be a little bit more dilated, or they happen to have a very high pain threshold. But it can also be quite painful to put in, especially in younger women or a person who's only had C-sections or never birthed, because their cervix can be closed shut. So that's one barrier, is putting it in. The second is the knowledge that it is very effective, but we say about 99.7%, so it's not 100%. And those people who do get pregnant have to know that they have an increased risk of an ectopic pregnancy, which is where the pregnancy grows outside of the uterus and not ideally, and often in the tube. And so that's something really important to know. I always say to my patients with an IUD, if you ever call me and tell me you have spotting or bleeding or if you missed your period, I'm always going to say, do a pregnancy test. And if your response is, don't you remember I have an IUD? I'm going to say, don't you remember I told you that it's not 100% effective? And then the third is that because the string that's attached to the IUD that comes out of the cervix, which is there so that it sits in the vagina so we can pull out the IUD when we need to, the downside is that that string, as well as the IUD itself, is a foreign body. And that means bacteria and other things like yeast can stick to it. In the best case scenario, it might just lead to increased risk of bacterial vaginosis or yeast infections, maybe because of that string harboring it. But in the worst case scenario, it can be an area where gonorrhea or chlamydia can climb up into that IUD and get into the uterine lining and cause a very dangerous pelvic inflammatory disease, an infection of the pelvis. So again, wonderful form of birth control, especially great for people who really don't want any kind of hormones or can't use them, but has some downsides. The other issue that you and I know is that it can really make your period very heavy and very crampy. Right. So if you start with a heavy, crampy period, I would personally, I can't say I'd never put it in, but I would really dissuade someone because it really can make it heavier and crampier because of this little inflammatory reaction. The data would tell us that just taking NSAIDs like ibuprofen over time can decrease that reaction. But I would say anecdotally, I don't know that I always saw that. I think there was definitely some women who, no matter what they did, the IUD continued to make their period heavy and crampy and needed it to be removed over time.
Right. I do tend to tell patients, like if whatever your period is, expect it to be a few days longer and a few days heavier. So if you already have long, like 7-day periods, like do you want to be bleeding for 10 days? It's possible that it could go to that,
Right.
So
right.
I'd say it's more ideal for someone who doesn't tend to have a very long,
I
heavy
agree.
period anyway.
I agree. Yes.
Yeah. And I don't find it as popular. Yes, with patients who want to avoid hormones, totally, but most people prefer the hormonal
Yeah,
IUD.
I agree. I think anecdotally, I agree with you. There was a period of time where I do feel like it was rising in popularity, and I still think it's a great form of birth control for those people who really didn't want or couldn't, right? Patients who, for example, are young and have had breast cancer and don't want to be on the higher levels of synthetic hormones of the birth control that we'll talk about. I think that's a good option. But I agree with you. I think the hormone IUD or the progesterone IUDs are much more popular for reasons that you and I both know make a lot of sense.
I have had to, your other point, I have had to remove, a copper, maybe even a hormonal for us, for patients who've had like frequent vaginal infections.
Yes.
And, even after trying to keep it in and trying to do a prolonged treatment course and still, so that's unfortunate.
Yeah. And then the truth is, in those cases, we don't know, is it the presence of semen in their vagina that's throwing off the pH because most of these women might not be using condoms, or is it the IUD itself? The only way to know would be to isolate things, meaning continue the IUD, but use condoms and see if that changes things. But people, I don't blame them. It's very frustrating to have recurrent vaginal infections. So they often point to the IUD.
Yes.
And it could be the IUD.
Yes, you bring up a good point, like the new information that's out that often frequent BV infections are linked to a partner being the source, and a partner needing to be treated. So that's going to be helpful to see if that helps the situation.
Yeah.
Okay, let's see. Let's talk about the hormonal methods. I guess we can touch on the hormonal IUD next.
Yeah. So the traditional one was called Mirena, and it used to be approved for 5 years. It was, again, a little piece of plastic that had progesterone. I was jokingly say impregnated in it. It's a terrible joke, but it was a progesterone impregnated plastic that's, again, shaped like a T. And then on the heels of that, Mirena also kind of gave birth to another brand called Liletta, which is very similar to Mirena. They both were initially indicated for 5 years, and now they're each indicated in America for 8 years as far as contraception. I say as far as contraception because we use them for other things. We use them in the space of perimenopause and menopause for hormone replacement sometimes. And for that indication, we would only approve it for 5 years to protect the uterine lining. But in this case, what it does is really thins out and antagonizes the uterine lining's ability to grow. So every month, as you and I know, when the estrogen tries to thicken the uterine lining, then someone ovulates and the progesterone shows up and then goes away and withdraws the lining. And the withdrawal of the lining is the period coming out. But if we constantly have progesterone in that uterine lining, then the estrogen can never work to thicken it up. So for anyone who gets worried out there and says, oh, but I don't want to miss my period, it's going to grow in there and back up. The answer is no. Your hormones are still working. I describe it as, for the most part, your own body's systemic hormones are working and you're ovulating to thicken the lining, but the lining cannot thicken because the progesterone is in there the whole time. And the data shows that probably 30% of the time, someone won't ovulate from that local suppression of ovulation from the progesterone, but it's not reliable. So it's a great option for someone who doesn't want systemic hormones. They want something more local. They might have heavy periods, painful periods, or they just don't want their period because it's safe to miss it. And we know from data that it actually even decreases the risk of uterine cancer by thinning out the lining so much. It's not necessarily ideal for people who either, again, don't want to use condoms and don't necessarily know if their partner is monogamous because they can get exposed to STIs like gonorrhea and chlamydia. It's not ideal if you have a lot of symptoms associated with ovulation. So those patients who say, I'm very moody around my period, I get a lot of ovulation pain, those are the patients who might want suppression of ovulation. And we'll talk about the pill and the patch and the ring separately. Right. So while this is a form of hormonal contraception, it doesn't mostly get systemic. And so again, that's Liletta and Mirena, which are 8 years of use in America. And then there's Kyleena and Skyla. So Kyleena is now 5 years, I believe. I think they increased it to 5. Skyla is 3 years. I would personally say, I like Skyla because it's easier to place because it's that 1 millimeter smaller barrel, but I dislike Skyla because it's only advocated for 3 years. And really, for the younger patients where you want it to be easier because it's smaller, those are often the ones who need longer contraception because they're not planning on getting pregnant anytime soon. So I would say I rarely put in Skyla or Kyleena because once we talked about it and a patient was going to embark on using some form of IUD, most wanted the potential for a longer form of contraception. And we should comment that like we could take these out anytime, meaning if someone doesn't like it after even a week or two, we could easily take it out. So even though it's indicated for 8 years, it doesn't mean you have to keep it in for that long.
That's a good point. So my office only I do Kylenas, but that's kind of an interesting point. Like maybe offering, if the Mirena fits, even the Mirena, for a younger patient, as long as they're measuring appropriately. I'm in my mind, I'm thinking, it could be more painful. Maybe it'll be more likely to puncture or move out of place. I tend to do the smaller one for women who haven't
well, and
had babies,
I agree.
But it's good to offer. It's good to offer and try it, because maybe they do want 8 years of protection,
Yeah. And I agree. I mean, I definitely think that it is easier to place the Kyleena and Skyla, but you also get more reliable amenorrhea, which you and I know what means less periods.
It's FDA, right. The Mirena and Liletta, I don't put in the Lilettas, but I assume that's also FDA approved for heavy periods, right?
Yes. Yeah. And it's more reliable to suppress it. And just the difference for everyone out there to know is Mirena was the first brand, and then Liletta came out on the heels of it and is like a teeny bit less hormone. But the honest answer is it's also more affordable. And so for patients where insurance isn't necessarily covering it, or for clinics where we purchase it ahead of time, we have to purchase them in bulk. And so it's cheaper for us to buy them.
Okay.
Yeah, because we're preemptively fronting the cost, which, as you know, can cost anywhere from $200 to $600 per IUD. And so these are things that we need to know about. Some patients absolutely want the brand Mirena. And so then we will, in our office, we will write them a prescription. They'll pick it up on their own at the pharmacy and bring it to us.
And all of these are very effective, almost on par with tying your tubes. Not tying your tubes, sorry, tubal sterilization. I've got to stop saying.
Yes. So just like with copper, the progesterone ones are 99.7%, which is great. But if you get pregnant, there is a 50% chance that you would have an ectopic. So if you miss your period and you were used to getting it, or you spotted or bled, anything different than usual, I tell patients, please check a pregnancy test, because the sooner we know, the better.
Okay, last category, since we are running out of time here, is hormonal methods, like combination or progesterone only birth control.
We're going to do this rapid fire.
Well, we could do, I guess I tend to like basket the pill, the patch, and the vaginal ring, combination pill rather, estrogen and progesterone. And I tell patients that, they all kind of work the same way. It's just the delivery method, how the hormones get in your body is different.
Yes.
So
I agree.
Maybe talk about how estrogen and progesterone are working. Maybe.
Well, and so these are the points that I've gathered through the years that I think are valuable for patients to know. There are 2 progesterone only non-pill patch ring options. So there's the Nexplanon, which is a progesterone insert. Essentially, it's that little tiny rod that gets injected right underneath your skin in your arm. And that can be very, very effective. It's relatively speaking, very easy for the clinician to put in their office with relatively little discomfort, because they can numb that area. And it's a small little incision that needs to be made to put the Nexplanon in. And that can last 3 years. And while many patients will have some irregular bleeding at the beginning, and anecdotally, I would say I do think some people feel hungrier, the data would tell us that this is progesterone only, that they reach pretty good rates of stopping their period, and that the weight changes over that time are actually on par with what would happen in nature. And so we have a lot of young patients who really do like that, and some older patients who like it because it's just convenient. You get it done once, and it suppresses ovulation, and you don't have to worry about it for 3 years. And then there's the Depo-Provera injection, which is an intramuscular injection. Same idea. It's suppressing ovulation, but you're getting that every 3 months. And so it's a little more cumbersome. You have to come to the clinic every 3 months. You either have to pick it up from the pharmacy and bring it, or your clinic might actually stock it themselves. I would say I do think people get a little bit hungrier on that as well. I think it's a wonderful form of birth control for someone who just can't or won't use a pill, patch, ring, doesn't want an IUD, and really needs something that they're willing to come in every 3 months for. So it can be great. But those are both progesterone only. And so the downside for some people is progesterone can make people moodier. Sometimes it can lead to depression. So, and once it's in, the Depo-Provera, when it's in because it's a shot and it stays in for 3 months. The Nexplanon you can have removed, but again, it requires a little procedure to remove it. So pros and cons as usual. And then, like you said, there's what we would call the combined hormone contraception, which is pill, patch, ring. And we'll talk about those. And then there's progesterone only pills. So let's do the progesterone only pills first, maybe quickly, because they're easier. Progesterone only pills are just that. There's two forms in America. There's the brand that we used to call Micronor, but it is only progesterone. It's a synthetic progesterone. It doesn't work by suppressing ovulation. So again, for some women, if they don't want ovulation to be suppressed, they might like it. It really only thickens the cervical mucus, and that's its primary mechanism to stop pregnancy. So from an efficacy perspective, it's not as efficacious. It's like 92 to 96%, and you really have to take it at the same time every day. Right. It became popular because we used to think that if you were lactating or breastfeeding, you couldn't use estrogen. We now know that's not true, but that old data has not really gone, meaning the data is gone, but the misconception is not gone. So a lot of people think that if they're breastfeeding, they can only use this progesterone only pill. The good news is that we came out with a new progesterone only pill called Slynd, Slynd. That's the only brand so far in America. And it does suppress ovulation. And the benefit that it's estrogen only is that some people can't use estrogen either because of high blood pressure.
Progesterone only.
Sorry, progesterone only. They have to use progesterone only because if they use estrogen, they might have a higher risk of blood pressure going up. They might have a risk of migraines that can be associated with estrogen, risk of clots. So there are some people who can't or don't want to take the estrogen and progesterone pills. So I'm glad we have a new product. I think it's actually really good. I think some people like the ovulation suppression and get a lot of good side effects out of it, but it's not always covered by insurance, and it's a brand, and it can be like $200 a month. So that's the downside to that.
Yeah. And the over-the-counter pill is also
the over-the-counter pill
only pill.
Yeah, and that's the first one, right? O-pill, which is the same as the one I was talking about, Micronor. So that's the one that you can either get through a prescription if your insurance covers it, or you can get it over the counter, which is great because the barrier is less. But again, it's not as effective. And my concern with it is that because it's over the counter, people don't hear the data about it being less effective. So access is better, but knowledge is less. And then they can absolutely potentially get.
You have to take it very closely, daily, set an alarm is what I usually say.
Take it same time every day. And then the combined hormone contraceptions, which are, as you said, the pill, there's many different brands, the patch, which there's only really one brand and one generic, and then the ring, which there are actually two different brands and a generic. And in general, the mechanisms are the same. They have systemic levels of estrogen and progesterone. They suppress ovulation, and that means less likelihood of getting pregnant through that mechanism. They thin out the lining of the uterus, so that's another mechanism. But they are synthetic hormones, and we're learning more and more that while synthetic hormones are so effective and actually quite safe, you and I have always known that there can be side effects and risks to them, and not everyone feels great on them besides the actual risks to them. So I think it's good to acknowledge those things, and hopefully in the future we will get newer, non-synthetic, bioidentical estrogen and progesterones in birth control forms that, for example, Australia has one brand that is bioidentical estrogen and progesterone. But I always try to explain to my patients that there are so many different brands of pills. You and I try to make sense of what brand we think might make sense for which patient based on a variety of questions we might ask. But the honest answer is that once we give the patient the pill or the patch or the ring, her body may respond very differently than what the book told us. And she might have 10 friends who are on one pill and they all love it, and then she might not like it. So unfortunately, a lot of it is trial and error. And I do really find that the more we can preemptively say to patients, have some patience, you're going to start the pill or the patch or the ring. We can decide together what brand and what formulation makes most sense, but really, really try to stick with it for 3 to 4 months at least, which is what I tell my patients, unless it's something really dramatic. Because once you get past that 3 or 4 months, a lot of your side effects will improve. For example, the irregular bleeding or spotting you might have will improve. And if it doesn't, then we've really given that particular brand a try. If we keep switching after like a couple weeks, we'll never know if any one particular brand is the one that's going to work best. And sometimes it's dictated even by their insurance, because not all insurances will cover all brands. They dictate to us which ones are covered sometimes, and sometimes we're limited because, again, an unreimbursed birth control pill or patch or ring can be about $200 a month. So that's a problem for many patients, right?
Yes. I mean, I feel like they're never getting the pill I'm prescribing. It's always dictated by their insurance, and they'll substitute with something else.
And if we write dispense as written to get it, then the insurance will give it to you, but they'll charge you, the pharmacy will have to charge you.
Whatever tier it's on, right?
Yes. I do think the new pills, a lot of the brands are really good about trying to give coupons and things like that, but we know that they don't last forever. Yeah.
So and how to decide between these, it's like kind of a combination of like, well, how often do you want to be thinking and doing something about your birth control? We
Yeah.
have these long acting methods like IUD and the implant, and then, the shorter acting ones, like the pill, you have to do something every day. The
Yeah.
patch is weekly,
Yeah.
and the vaginal ring monthly, and then the
Yeah.
depot shot every 3 months. So,
Yes.
so those are things to think about too.
Yeah,
So,
yeah. But I would love to just quickly, I know we're running out of time, talk about the misinformation about the pill, meaning there is clear information that we didn't always know as physicians, that we didn't always disclose because we didn't always have time or knowledge or maybe even buy-in about it. About there are some negative, we know the obvious negative risks, right? Risk of hypertension, risk of blood clot. Those are clear risks. We talk about those with our patients. There are probably other side effects, and we talk about the obvious side effects. You might have spotting or bleeding, things like that. There are potentially long-term issues that we don't necessarily know about. But the problem nowadays is that because this natural movement has come about saying that hormones are bad for us and we shouldn't be on them, there's so much fear mongering around the pill that so many women that you and I take care of are either scared to use the pill, or they have a lot of fear and anxiety that they used the pill in the past and they think that's the reason for their fertility issues. They think it's the reason because they've read these studies that they picked the wrong partner because of the pill that they chose and it changed how they viewed their partner. I mean, things that are really unfair to women. And I always say it's a very anti-feminist movement that is cloaked in female empowerment because they think the doctors and books that have been written about it think they're trying to empower women to say, like, I don't want the pill. But you're really taking away their opportunity to absolutely take control of their fertility sometimes in ways that is not only unfair, but potentially dangerous with the concomitant decreased access to being able to plan your pregnancies or maybe terminate a pregnancy. So I really feel sad for women right now that they have to hear all of this. And I think the more we as clinicians can say, listen, we're not saying the pill is perfect. We're not saying the pill is right for everyone. We know there are side effects. We are willing to take those risks. And it might be worth that risk to you because an unplanned pregnancy will be worse for you, right?
Absolutely. Oh my goodness. I mean, you struck upon exactly why I wanted to do this episode, because I do think that some of this, like, the health influencers out there, this natural movement that's going on out there is a little bit insidious. And I do think sometimes, not everyone, but I think a lot of it is a way of kind of brainwashing women to be, kind of, suspicious of things that have empowered women and, made it so that women can dictate when and if to have children, So I think we do have to be suspicious. And like, to your point, yes, of course. No, I don't. I think most doctors aren't trying to get you on a drug with all these side effects. We're trying to help you. And it is good to be honest about all these side effects and try to work with a patient. And I agree with you. I usually say, try something. We can tweak, we can try something else. There's all these options now and hopefully more to come.
Yeah.
So
the
thanks
hard
for
part,
that
you
message.
And I know, we know it comes with a lot of patience, which is challenging because as doctors and as women, we don't have the time necessarily to try a bunch of different things. But unfortunately, if our patients don't realize that the patients need to have patience with whatever they're going to try, then we lose them as an audience. So I think we can do a better job. And so I'm so grateful to platforms like this, because if we can educate people en masse like this, it'll be great.
Shieva, thank you so much for your time today and going through all these birth control options in under an hour. So I thank you for that. I know it was a little bit rushed, but I hope we'll chat again in the future.
Absolutely.
So tell my audience a little. Well, do you have closing thoughts? And then please tell my audience where we can find you. They can find you and follow you.
Yeah. I mean, my closing thoughts would be, please, please, please don't listen to anyone. And that includes doctors or influencers who try to make blanket statements that anything is either all good or all bad. And the honest answer, if we're being really honest, is as doctors, I don't think any of us ever act like anything is all good. Whereas I do feel like we hear a lot of influencers say there are certain things that are all bad. Every single form of birth control you and I talked about can have pros and cons. And we might have more experience where one might be a little bit more preferential than others, but there are pros and cons to everything. And so I caution anyone to really just pay attention. If you hear people speaking hyperbolically, like it's always good or always bad, that's a sign that you need to not listen to that person. And then they can find me mostly in social media. It's mostly Instagram. I don't really like the other platforms very much. So on Instagram, it's DrShievag. So Dr. Shieva G, which I laugh because the VAG sounds like vagina, but it's because my name is Dr. Shieva Ghofrany. So Dr.
Perfect.
Yeah. And then my website, which is also drshievag.com.
Thank you so much.
Thank you.
Well, I know we've run out of time, so I'm going to let you go. I want to thank you so much.
You.
And this was great. I'm going to leave with my closing thought. The patriarchy tries to limit women's access to birth control because controlling women's reproduction is a powerful way to control women. Unplanned pregnancy limits women's time, ability to get an education, ability to work outside the home, achieve economic power, and have freedom and autonomy. In the Gynarchy, we're grateful for birth control and recognize it as a powerful contributor in enabling women to achieve economic independence and to choose when and if they would like to have children. So down with the patriarchy and up with the Gynarchy. Thanks so much for listening. If you've enjoyed this show, please consider leaving us a review on the podcast platforms. Thank you so much. Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.